Good evening, everyone. My name is Meredith Toohey, and I'm the Director of Programmatic Operations at the American Nutrition Association, the ANA. The ANA is very pleased to be hosting Abra Pappa tonight to explore the intersection of disordered eating and digestive disorders. Abra holds a master's degree in nutrition and functional medicine from the University of Western States and is a certified nutrition specialist. Abra has worked in the field of health and nutrition for over 15 years. She has a thriving practice in New York City, is a frequent speaker and lecturer at corporations around the tri-state area, and runs a food and wellness blog, Abra's Kitchen. Welcome, Abra.
Hello and welcome. My name is Abra Pappa, and in the session today, we are going to be talking about the intersection of digestive disorders and eating disorders. So let's get started. I don't have any disclosures. I am the owner of Abra Pappa Nutrition, my private practice. I'm also the co-founder of IFNS, a CNS supervision program, and I'm the publisher of Abra's Kitchen. So our objectives for today, first, we want to understand the prevalence of digestive disorders in the eating disorder population. We're going to talk a little bit about the most common digestive symptoms in the eating disorder population. We're going to discuss that pathophysiology of digestive disorders and eating disorders. And then most importantly, or my favorite part, is that we're going to really dive into some practical tools. So we'll talk about case studies, your questions. We're going to even go through language prompts. So when I was preparing for the session today, I was really thinking about how this topic is best suited as a conversation. And of course, this isn't a conversation. I'm going to be leading the session, but I reached out to several of my CNS colleagues and I asked them for questions. So what about this topic feels confusing or overwhelming, or how can I support you to better understand how to identify eating disorders and that sort of intersection of digestive disorders in your practice? And you all came through in a huge way. So I am so grateful, because I think that it's going to help really put this into a more practical application of understanding how we can address these digestive disorders within this population. So thank you to all of my colleagues, and I can't wait till we get to that part. But first, let's lay some foundational information. I am actually going to start today with a quote. There's no magic cure, no making it all go away forever. There are only small steps upward, an easier day, an unexpected laugh. And there's something about this quote that really speaks to me in regards to one of the most fundamental shifts that happened for me as a practitioner when I started to work with the eating disorder population, is that I had to change my pace. So I think if we can approach today's topic with that in mind, is that the pace will shift. They are going to be small incremental shifts. We are encouraging a sort of longer journey towards healing. And that's how I hope we approach today's information. So I'm going to start with laying out two sort of definitions, if you will, just so we're clear about what we're talking about. So I shared this in a previous class that I did for the ANA on eating disorders and functional nutrition, where we talk about that there is a spectrum of eating behavior. So over here on the far right, we have the eating disorder, which is going to be behaviors that meet that DSM-5 diagnostic criteria. In that previous session, I went through the DSM-5 diagnostic criteria, so you can go back and watch that. But in that eating disorder population, these are really specific behaviors and they have diagnostic criteria. And then in the center, we have this really large bucket of disordered eating. This is problematic eating behaviors. They don't meet that clinical diagnosis for an eating disorder, but we're seeing a lot of problematic behaviors. And I will tell you that I think that this is a sort of a very large population that seeks out nutrition support and seeks out support from the functional medicine community. The vast majority of literature and research is done on the eating disorder population, not so much on disordered eating, but today we're going to be talking about both. And then the other definition that I want to go through is functional gut disorders. And this is the terminology that most literature, most papers are using when we're looking at eating disorders and GI disorders. And what a functional gut disorder is, it's things like IBS, bloating, constipation, diarrhea, gastroparesis, GERD, reflux. Essentially, these are gut disorders where we're unable to identify a structural problem. There's no biological marker. It's a main abnormality in the way the body works, and it's a biopsychosocial disorder. So this is excluding things like IBD or celiac disease. So this is a slide that I also presented in my other session, but I do want to look at some of the statistical information that we have here. So when we're looking at that subset of individuals that have a functional gut disorder, it's estimated that about 16% also have a co-occurring eating disorder, up to 44% have disordered eating, and 50% have a psychiatric comorbidity. We'll talk a little bit more about that later on. And the symptom severity tends to correlate with psychological distress. And then when we look at the population of individuals with a diagnosed eating disorder, up to 98% also have co-occurring functional gut disorders. So that's why this topic is so incredibly important, because you really can't separate eating disorders and digestive disorders when 98% of the population has a co-occurring functional gut disorder, and estimated 70% has psychiatric comorbidity. This slide is from a paper from Santo Nicola, and this is just showing the most prevalent GI symptoms for the three primary, if you will, eating disorders: anorexia, bulimia, and binge eating disorder. These are things that I'm seeing every single day in my practice: postprandial fullness for sure, constipation, bloating, some heartburn, regurgitation. And this is where the vast majority of money is spent in research, is looking at these three eating disorders, with the majority of it really being spent on anorexia nervosa. And I will try to separate that out when we're talking about studies specifically, which eating disorder it has specified, the research has specified. So why are folks with eating disorders so susceptible to GI issues? Well, we know that the gut-brain axis is a really big piece of the picture here. So when we're looking at individuals that are have a higher prevalence of eating disorders, or that tend to have a higher propensity to develop an eating disorder, they tend to be highly sensing individuals, highly empathetic individuals. And I can really relate to this feeling, and I'm sure many of you can as well. So, people that really are internalizing a lot of energy from the external world, but it's felt in the body in very, very real ways. So that gut-brain axis is a big piece of this puzzle here. Behaviors that individuals use in their eating disorders disrupt normal digestion. We'll talk really specifically about that, because I think this is an important piece to understand in a concrete way. Eating disorder behaviors change the physiology of the digestive tract. Malnutrition alters the microbiome. The microbiome alterations increase the risk of functional gut disorders and increase the risk of anxiety and depression. We know a lot about the microbiome as CNSs, right? So understanding how malnutrition is going to alter that microbiome, and really looking at the details of how the microbiome is participating in this physiology. So we have a lot of chicken or the egg syndrome going on here. We could talk about, how the eating disorder behaviors lead to GI symptoms, and how GI symptoms lead to eating disorder behaviors. So first, we'll look at these eating disorder behaviors. Food restriction leads to delayed gastric emptying, that sensation of premature fullness. Also flattening of the villi, those like little projections in the small intestine that help to absorb nutrients, right? There's a flattening of the villi in food restriction, i.e. decreased nutrient absorption. Low food intake and/or purging can certainly lead to constipation. With purging, we have weakened esophageal sphincter, leading to GERD, and laxative abuse and pericolonic function, in addition to, of course, many, many other malfunctions, if you will, or GI symptoms. And then how GI symptoms increase the vulnerability to develop eating disorders. Well, if an individual has GI discomfort or pain, they find that they can restrict food, and that manages their symptoms. And in a vulnerable individual, that can absolutely lead to more eating disorder behaviors. The therapeutic elimination diets that are oftentimes used for GI symptoms can absolutely set the stage for restriction. And we'll talk about that. We'll talk about if that's a safe intervention in this population. I guess you can probably surmise at this point it's not. A desire to eat perfectly even when the diet doesn't relieve symptoms, right? So kind of putting all the blame on food when there's these GI symptoms, and no matter what I'm eating, I'm not feeling good, I'm not feeling good. It's the food, it's the food, it's the food. That can absolutely lead to eating disorder behaviors. That rigidity around changing diet, oftentimes from a fear of food and a fear of symptoms. Strict adherence to diets can create this restrict and binge cycle. So I want to talk a little bit about this sort of physiology picture, the food and signaling. And this is honestly a piece that I speak with my clients a lot around, so they can better understand how this digestive system, this digestive process is disrupted in eating disorder behaviors. So this should be a review for most of you, but we're going to go through it anyway, because I always find it really helpful to sort of put my brain into this place of like, oh yeah, that's right. That's what happens here. And if that's not happening, then what else is happening, right? So we have arrival of the food in the GI tract, which produces signals from this gastric distension. Nutrient and non-nutrient elements and gut hormones are released from the enteroendocrine cells of the GI wall. Then that distension of the gastric wall to accommodate food stimulates the vagal afferent fibers to signal the perception of fullness. So this is that first time we're getting that signal of fullness, which can help to sort of control meal size, if you will. Gastric emptying happens, the signals rising from that distension begin to reduce gradually, moves to the antrum into the small intestine. The antrum plays a crucial role in this perception of fullness and satiety, and helps to determine meal termination. Simultaneously, nutrients are going to influence that postprandial GI function, such as motility, hormone release, with effects on appetite perceptions. So we have a sense of sort of what signaling clues are happening during the digestive process. Well, when there is a disruption of any of this process, of the physiological processes of digestion, this can affect eating behavior or provoke GI symptoms such as exaggerated postprandial fullness, nausea, and bloating. So when restriction is on board, that is going to impact signaling. When long-term restriction is on board, that may impact long-term food signaling, or that sensation of satiety or that sensation of fullness. So in this paper, it's important to remember that although it's noteworthy that several studies have excluded the presence of structural or metabolic GI disorders, I wanted to mention this piece because, like I said, most of this is around functional gut disorders. We're going to be talking more about that sort of IBS and that symptom picture in eating disorders. But it has been noted in studies that a structural illness like celiac disease can increase the likelihood of developing an eating disorder because of how an individual might pay attention to their food, right? Really being cautious of, well, if I'm eating this, it's making me feel a certain way, and increases the way that they're looking at their body or thinking about their body. Food-related GI symptoms can result in chronic dietary restriction. So although the majority of the research is on this sort of functional gut disorder, including some of that food signaling, we also have to remember that even structural gut disorders can lead to eating disorder behaviors. So let's talk a little bit about the gut microbiota. There is very little research on the gut microbiota and eating disorders. However, there is enough research that I think it's pretty fascinating to mention. And my hope is that we can continue to put a little bit of dollars into that realm so we can better understand what this picture looks like. So we know that there is this bi-directional communication system with the central nervous system, that gut-brain axis, right? This microbiota is doing a really big job in regards to signaling how we're feeling, how we are feeling. And so how is this microbiota disrupted when eating disorder behaviors are on board? Well, in this paper, they specifically were looking at anorexia, and it showed a difference in alpha diversity compared to healthy controls. So specifically, they found that there was a decrease in a specific bacteria called Roseburia, which is really important just for overall gut health and immune defense through the production of short-chain fatty acids. And we know how important short-chain fatty acid production is in the overall picture of microbiome health or gut health. So this reduced butyrate correlated with increased anxiety and depression scores. That shouldn't be terribly surprising to anybody that's listening to this, because we know how important butyrate production is in regards, again, to full gut health, but also in regards to this, to the neurotransmitter development within the gut. In the anorexia population, they also saw an increase in Enterobacteriaceae and Methanobrevibacter smithii. So two bacterial species which are capable of extracting more calories from food through the transformation of hydrogen into methane. So, that's an interesting point here, right? Because what happens with increased methane production in the gut? Well, we know that that slows that intestinal transit time and can predispose an individual to constipation and bloating. And I will tell you from more of an anecdotal perspective in my own practice, certainly with individuals that are in recovery for anorexia, we are seeing so much constipation and bloating. That is the primary GI complaints that I hear all day, every day: constipation, bloating, constipation, bloating. Some authors also suggest that that increase in the Enterobacteriaceae may directly activate satiation and satiety pathways. And research suggests that dysbiosis is a critical mediator of anorexia pathology. So decreased appetite, early satiety, and body image distortions. That's a really important statement there. And again, I hope that we are able to spend a little bit more money in research to better understand what that looks like, and more importantly, to shift or increase our toolkit in regards to recovery for this population, the recovery process for this population. So in a 2016 study, also with patients with anorexia, they noticed that there was an increased level of bacteria that like to thrive on eating that intestinal mucosal layer. Well, we know what happens there. Not good stuff, right? That's going to disrupt intestinal barrier integrity, increase gut permeability, increase the risk of autoimmune disorders. But this is really interesting. They found that during the refeeding process, when the microbes were disrupted through the presence of food, that it caused a lot of GI discomfort, partially because the microbes were trying to push the host back to status quo. So they wanted to be in that restricted state, in that non-fed state. So I think that's pretty interesting. So this is a unique study because it reported the microbiota diversity and short chain fatty acid concentrations, both before and after refeeding, in comparison to a healthy control. And what they found was that upon weight gain, the microbial richness increased, but dysbiosis and short chain fatty acid concentrations did not improve. So GI symptoms also did not improve. So this is a really interesting study. It's flawed in that it was a pretty small cohort. Many of these studies are flawed for that very reason. This is why we need more research. But I do think even though it is a small study, that's providing some interesting information, right? So we know that that microbial richness is increasing, but there isn't a shift in that dysbiosis. Now, my brain, of course, goes to, well, I think that there's some support that we could still provide to this population, right? There are things that we know how to do in a dysbiotic picture or when short chain fatty acid concentrations are low. And I hope that that's where your brain is going to. So they're saying in this study that this points to new leads to help modulate intestinal microbiota. That's where my brain's going, right? In order to improve the outcomes of standard therapy. And that is my big, big hope, is that, again, we can keep spending some money in this realm to help support these individuals in regards specifically to digestive complaints and the eating disorder recovery process. I added this paper in here because I think that it's just important to highlight that functional gut disorders can persist independently on the outcome of the eating disorder. And oftentimes I will certainly have clients that will be like, I thought it would all go away when I recovered, right? The recovery process it's hard, man, it's hard. And the hope was that all these GI symptoms, they would just get better once refeeding happened, once there was a sort of normal caloric load, once that relationship to food shifted and changed, once the individual started to feel like they had a different relationship with food and body. What we're seeing is that those gut symptoms can persist. And so we want to do our very best to see how we can support these individuals to alleviate or reduce some of these gut symptoms. So let's talk a little bit about treatment options. This is a discussion. This is not a definitive guideline, but let's talk a little bit. So the first step is that I want to make sure I highlight how important it is to assess with your clients that are coming in. So we want to, first of all, after you've watched my initial call, all of you will have on your intake forms just the simple question if there is a history of eating disorders. And we'll talk about that a little bit in the case studies too, just the sort of nuance around that piece. But another question that you can ask if you're working with somebody that is recovered, did these GI symptoms predate the eating disorder? This is actually really good information to have and to better understand. This just happened yesterday in an initial consult for me, where in fact, this individual did have these same GI symptoms starting at the age of 6. And the eating disorder behaviors didn't really increase dramatically until the last 18 months. So, you know, I'm thinking about the GI symptoms in a little bit of a different way because it's been a chronic problem that's been on board for quite some time. Is there a family history of GI issues? Can we recommend these individuals for testing? This is an area that our toolkit is pretty robust, right? This population can do really well with some more information. Always assess recovery status. How long have you been recovered for? Are you open to talking a little bit about your recovery process? What did that look like? Ask those questions, ask the questions. Evaluate for eating disorder behaviors that are still present. I am just very straightforward in a really safe space with my clients to ask these questions. Is restriction still happening? Would you consider your diet right now a restrictive diet? Is binging still happening? Again, yesterday, this was the question I was asking. How frequently are you binging? What do your binges look like? Are there any other compensatory behaviors? Are you purging? Are you using laxatives? We need to have this information. So assess. And then what are some safe interventions in eating disorders? Well, I really like to think of this non-reductive philosophy when it comes to food in the eating disorder or disordered eating population. So I am thinking about increasing therapeutic foods. We all have a really good training around GI health here. So you should know when fermented foods and pre and probiotic like foods are appropriate if they're tolerated, but thinking about increasing therapeutic food, educating around nutrient diversity. This is something that I found to be really, really beneficial in my practice. Talking about how an abundance of nutrients makes such a difference in an individual that is having GI symptoms. Now, I completely understand that for some people, if they're only eating 3 or 4 foods because they're the only ones that don't cause them symptoms, it will take some time to get to this nutrient diversity. But I'm approaching it from an abundance mindset, right? So can we get in more incredibly wonderful nutrient-dense foods? Can we approach this from a perspective of abundance as opposed to restriction? Supplementation, another area that we're really well trained in, and this is very appropriate for this population. So can we offer some motility support, magnesium, probiotics, prebiotics, antimicrobials in the right circumstances, intestinal barrier support, of course, very personalized, highly personalized. We all practice personalized nutrition, but supplementation can be a piece of this. And I think it's a piece that has been missing in sort of standard care for recovery. So if an individual comes to you several years post-recovery and they're like, I'm still having all of these GI symptoms, can we lean into the supplemental world and help support them a little bit? In addition to, of course, all of the other things we're going to talk about. Eliminate foods only if they're known triggers. And I know that that's a challenging statement because it's just you're not always able to know. But I'll give you an example. If I have a client that says to me, listen, every time I eat onions, I feel so incredibly sick. Well, let's do a trial without onions. Compared to if an individual says to me, whenever I eat any carbohydrates at all, like any carbohydrates, I can't tolerate it. I'm going to push back there a little bit. I want to better understand what that looks like, right? Because is that the eating disorder talking, or is there a GI symptom that we can sort of parse out? So eliminate foods only if they're known triggers. Get real comfortable with referrals. If something feels out of your depth, or if you feel like, there are topics that are coming up that this individual would do really well with some additional support, get really, really comfortable with referring out. And I'm not just talking about referring out to other nutritionists. I'm talking about referring out to all different types of specialists, which we'll talk a little bit more about here. But I do believe that all CNSs should have a robust list of therapists in their area that they really love and trust, because that is just such a beautiful, sweet spot of combined work when an individual is able to be in a wonderfully supportive therapeutic relationship in addition to this nutrition relationship. If anyone is listening to this that's in the New York area, I'm very happy to share my robust list of therapists that I love and trust that I have referred to for over a decade. I want to remind you that a CNS toolkit is actually wonderfully equipped to support this population. So although, in the last class, we talked a little bit about how we have to increase some of the education in this area, I think when we're getting into the specificity of digestive disorders in this population, we actually do have a pretty robust toolkit. We just have to be careful to not dive into some of the interventions that may cause harm, which we'll talk about in the next slide. So also deepen your non-food intervention toolkit. I talked a lot about the gut-directed hypnotherapy in my last class, which is a really wonderful resource. There is a fundamental paper that looked at gut-directed hypnotherapy in comparison to a low FODMAP diet, and the gut-directed hypnotherapy group performed better, felt better, had less GI symptoms at the end of the study. So I think this is a really wonderful tool. Vagal nerve stimulation, really incredible for this population. Humming, singing, all the things can be very, very supportive. So dive deep into that area a little bit too to provide some information for your clients. Breath work can be really supportive. Yoga can be really supportive. Pelvic floor therapy, holy moly, another area that I really recommend having a robust area of, a robust list rather of referrals. There is a lot of individuals in this space that really do need pelvic floor therapy, and it makes a huge difference, especially in the population that is chronically constipated, has been constipated for years. Pelvic floor can do a lot of good. Depending on the condition, of course, we also have squatty potties and wedge pillows and avoiding tight clothing. I'm just mentioning these as reminders that there are non-food interventions that we can have education, we can educate our clients around that can be really supportive tools. And then things that may cause harm are these really strict diets, right? So like really strict elimination diets that are absolutely not appropriate in the eating disorder population or in individuals that have disordered eating behaviors. Things like the AIP diet, specific carbohydrate diet, really strict low FODMAP diet, these punitive lists of like no foods that are red and yes foods that are green. I see these lists all the time. Doctors hand them to patients just sort of willy-nilly. You have IBS. Here's a list of foods that you should never eat, or if you ever eat them, you will just be sick for the rest of your life, right? Like that's the messaging that comes across. So we just want to be really cautious that our language around food is coming from a very supportive, abundant perspective. Again, if there are known triggers, of course, we're going to gently remove those known triggers, but in this population, we don't want to take all the things away, right? Especially all at once. So we might do let's just do a little trial where we take the onions out. And I'm going to talk about that in more specifics in a little bit. Right now, hold on, pause for water. Okay, so we're going to get into your questions. And within this section too, we'll talk about the questions, and we're going to talk about some cases specifically. So the question was specifically around individuals that have multiple GI issues, a history of eating disorder that was not revealed initially, which happens. The question is, how do we approach dietary changes and what language to use? So I said that I would give you language prompts because I had requests specifically for scripts. And I think that was an interesting and heartfelt request that oftentimes we just don't know what to say in these situations. So by no means you need to repeat these things exactly, but I know as a practitioner, it was helpful when I was learning some of this sort of language nuance to just have an example. So here's an example. Thank you for sharing your eating disorder history. Your relationship to food, both past and present, is so important to our work together and can even help us better understand the root cause of your GI concerns. So I first am always really gracious to say, this is important information for us to have, right? We're partnered together on this journey. Thank you so much for sharing this. So start there. And then you want to assess, so we can go back to my assess slide, assess treatment and recovery status. So, thanks so much for revealing this. And can you give me a sense of where you are in your recovery? How long ago, did you do inpatient? Like where are you in your recovery process? Set really clear expectations. So I don't mince words here. So I will say to an individual, listen, I want to be really clear. I would not be doing a good job here if I recommended a really strict elimination diet. So we're going to have to go about this a little bit of a different way. Are you on board for that? Use neutral language when it comes to food. So none of this punitive good and bad, but really neutral language. Onions aren't bad. Maybe onions aren't feeling so great for you right now. And we can work on that. Let's find some foods that feel amazing for you right now. That's not neutral so much, but I want to bring in the positivity, right? Set timelines for dietary shifts. This is a really, really important piece of the puzzle. So if there is somebody that's like, man, I'm just so symptomatic. I'm so symptomatic. And I'm really noticing that whenever I have dairy, I'm in agony. I'm in so much pain. I'm not going to tell that individual to continue eating dairy, right? But what I might say is, listen, let's very gently and as partners together on this journey, let's do a short-term removal of dairy and see how that feels for you. I just want to make sure that we stay in contact and that we communicate throughout this whole process to see how this feels. We're going to eliminate dairy for 2 weeks. Set a timeline, set a clear timeline. I love to say this all the time, embrace curious compassion. So what we want these individuals to do is to become certainly more compassionate in regards to their GI symptoms and embrace a little bit more of a curious attitude when it comes to the GI symptoms, as opposed to this, oh my gosh, everything is, my world is crumbling because I'm bloated today. So embrace that curious compassion. This next question is similar, but there's a little nuance here, so I put this one in as well. So the history of the eating disorder was revealed, and the individual is in fact recovered, multiple GI issues again. We don't want to trigger any type of eating disorder behaviors, but is there anything else that we should be saying and doing? So again, I put this same prompt because I think that this is really wonderful to just reaffirm, thank you so much for sharing your eating disorder history. This is so important to our work together. This can provide clues to be able to support you to feel better. Communicate every step of the way. You aren't alone on an island, right? When you're working with an individual that has said, listen, I had an eating disorder, I'm recovered, I'm coming to you because I have these GI issues, communicate with them. Well, what else have you tried in the past? I want you to be really clear with me if there's anything that we're discussing that doesn't feel right or feels triggering. We can shift and adjust language. Communicate with your client. Restrictive elimination diets, they need to be avoided. In an individual like this, it's just not going to be a supportive tool, so don't use them. Don't use them. We've got that really deep toolkit. So reach into that deep toolkit of non-dietary interventions and pull some of those things out. And maybe you start there, right? Perhaps it's somebody where you can go down a path of adding in some supportive supplementation and seeing how they feel first. Hey, let's try this out first before we touch your food. And then we can look to see if there's any resolution. So don't blame the food. Don't make it all about the food. Those are the only things that I would say that could be triggering. If you're like, oh, that's definitely the problem. That's definitely the problem. We want to remind individuals, this is a good slide. I'll go back, but they don't always have to go on this sort of scavenger hunt to figure it all out, right? This is a language prompt as well. Bodies are confusing and can be uncomfortable. When you're symptomatic, it's not a sign that you did something wrong, that you messed up, and oh my goodness, I could give you 100 examples of this, 100 examples where a client's like, well, I ate 3 bites of almond butter today and my stomach is really bothering me, but I had 3 bites of almond butter yesterday and I didn't have any stomach problems. Well, what else was happening in your life today? Well, I had a really stressful conversation with my boyfriend. Well, do you think maybe it was that bothered your stomach and not the 3 bites of almond butter, right? Like, but there is this sort of tendency to go on this hunt, like, I need to figure this out. What's going on? What did I do? What did I screw up? Can we create room for more of that curious compassion, right? Be compassionate about the idea that, listen, sometimes we have symptoms. Sometimes we do. I don't ever want to set the expectation for clients that you will never in a million years have a stomach ache again. I'm going to fix all the problems, or you will never feel bloated again. Can we set realistic expectations? I'll say to clients all the time, listen, if we get to 60% symptom relief, that's incredible. That is amazing. I will do cartwheels down the street. I can't wait for that. That's so fantastic. You know, can we normalize that we all have GI symptoms sometimes? And I'll share that. I'll share that with clients. Hey, listen, I had a stomach ache yesterday too. It honestly had nothing to do with what I ate. I just had a stomach ache and then it went away and I'm fine, right? So can we normalize this piece so there isn't that like tendency to scavenger hunt? And I do see that there are practitioners in our field that engage in that scavenger hunt because like we want to figure it out. We want to get all the data. We want to put the puzzle pieces together. And this population, we want to have a little bit more of that curious compassion and a little bit more normalizing that GI symptoms will happen, but we're going to try to get to a place where there's some symptom relief here. Okay, the next question is, those who have no self-awareness that they're obsessing about restricting food or restrict food at the sign of any symptom, how to suggest that they get evaluated for disordered eating. This is so common. I'm so glad this question came through. I have worked with so many clients that fit into this category that there isn't that self-awareness that there's very severe restriction happening, because we need to remember at the end of the day, restrictive diets are championed in society, right? Like, good for you, you only eat 3 foods. That's amazing. You have the most incredible willpower, right? So we have to remember that this is something that's challenging. So here is your language prompt. This is pretty much exactly what I would say. It's my professional opinion that you would benefit greatly from a deeper exploration of your relationship to food, specifically your desire to restrict food intake. I'm not mincing words here. I'm being very straightforward and honest, right? Hey, you're restricting food, and that can be really problematic. And I think you'd benefit from doing a bit of a deeper dive. I'd like to send you a recommendation for a wonderful therapist who specializes in disordered eating behaviors. Are you open to speaking with her? What I would say here is that you want to be careful about language, because of course we can't diagnose, and be careful of saying, I think you have an eating disorder, right? I'm picking up on some disordered behaviors around food. That can be okay. I'm picking up on some disordered eating. Are you open to speaking with somebody about this? Have a referral list of therapists. Like I said before, it's a very, I just think everybody should have one. And also feel comfortable walking away. There are going to be some individuals that really are not suited to go down the nutrition route until they address this other bigger elephant in the room. And be prepared to say, hey, look, we've been working together for a couple of weeks now, and I was really clear with you about these behaviors that are problematic, and I'm concerned about them. I don't feel comfortable working together anymore. Please reach out to those therapists, and when you're ready to re-engage, I am here for you, but I want you to be working with a therapist first. I have absolutely done that in my practice, and it's hard and it sucks because it feels like, well, I'm the only person but you have to be ready to walk away, to feel comfortable to walk away, so you can support this person on a deeper level. So we talked about this piece. The next question: those who use symptoms as an excuse to avoid food reintroductions as planned. Oh my goodness, I live in that space. And those who fear foods will cause symptoms and avoid expanding the diet. So, under the language prompts area here, I say education around diet diversity and microbiome health would be really appropriate in this space, like reminding, in a very supportive, gentle way, hey, listen, you know what I think would be really great today? Let's talk a little bit more about understanding why eating more foods is important for the microbiome. And then we also want to go back to that piece from a few slides ago of, we have to normalize that there's going to be some symptoms and be really compassionate about that. Listen, it's hard when your body's doing uncomfortable things. And there might be some symptoms, but we have to move through this space because eating only 5 foods is not sustainable long-term. We have to get you to a different place. Deep in your toolkit, deep in your toolkit, deep in your toolkit. This is when we can bring in, hey, look, I want to bring in these foods, but I want to bring these foods in when you're in a really calm state. So can we work on some meditation? Can we work on some gut-directed hypnotherapy? Can we work on some, vagal tone exercises? Can we work on some things sort of outside of the food, see if we can get a pattern going with that, get the individual into a really calm space, and then maybe bring food in. I'm also not afraid to actually do the food introductions together, even virtually. So I'll say, hey, listen, on our next session, bring an apple to the session. Bring an apple to the session. I'll bring an apple to session 2. Let's eat one together, because then it could be a sort of calmer state and you're really, really supportive and holding space for it not to be this fear-based introduction. Can talk a lot about how the client is relating to stress, reintroducing food slowly but frequently, and I'll always refer out to a therapist. During this reintroduction phase, being in a therapeutic relationship can be super, 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 super helpful. I want to share a case that's pretty specific to this because I think it was a very, very interesting case. So Carolyn, of course, name has been changed, 33-year-old marketing executive. She had recurrent SIBO for 3+ years. By the time she came to me, she had had 2 negative tests in the last 10 months, but she had a very serious fear of food. So she was eating about 10 foods. She had a healthy diet, right? So it's not like, her 10 foods, she was sort of bordering in that orthorexic realm, right? I only eat these things and I only eat them in this specific way. I can tolerate a teaspoon of ghee and I can tolerate this much. She tracked and logged everything, not just her food, but her exact reaction to the food every single solitary day. So she absolutely had disordered eating patterns and she was aware of it. She was aware of it. She was like, I know that there's restriction that's happening here. And I think a lot of it is because I'm fearful of food and fearful of going back to some really intense GI symptoms. But she blamed everything on food, every single symptom on food. She would say, oh my gosh, I have this really weird pinky, like the top of my pinky is swollen. And yesterday I had like 2 carrots instead of 1 carrot. And I'm pretty sure that's why my pinky is swollen. So there was this hyper vigilant focus on what she was eating and how her body was responding to it. So we did, when I say slow food introduction, I mean, it took 6 months to get a couple new foods in. And during that process, I really was able to, she was able to identify a pattern of food blame, right? So with some gentle prompting, she was able to see how she was really putting the blame on all the food stuff, instead of looking at maybe some of her concerns in life or her massive stress load in life and how that was contributing. She had a lot going on in life. So she would go into this spiral of self-blame, which you will see, and it reinforced this desire of total control over the body. And that piece is so, 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 so important, because in an individual with disordered eating or an eating disorder, this control piece is going to keep on coming back. And if you're working with somebody that's in that space, like in this question previously, right? They use symptoms as an excuse to avoid the food, or they fear food will cause symptoms. That's part of this control. And then they're hyper focused. Well, if I can control exactly how this food is going to behave in my body, or I know I can have 1 carrot, but not 2. I can have 1 spear of asparagus, but not 3, right? A strict low FODMAP diet in the wrong individual will create this obsession. So that control piece, that self-blame, it's my fault, it's my fault, it's my fault. I need to control this better. I need to control this better. So we did gut-directed hypnotherapy that was really, really supportive for her. I actually referred her out to a practitioner that she worked with. We brought in a much greater awareness of external influences outside of food, the environment, and stress response. We had a very interesting breakthrough in this case. We were probably at month 4 or 5 and still just so challenged around this sort of self-blame spiral and blaming everything on the food. And I said, in the last, since you started to develop these GI symptoms, has there ever been a time that you felt like you were able to tolerate more foods in a sort of open, flexible, free way, that it felt good to you? And she said, this is fascinating. I said, well, I was in Paris. I was visiting a friend. And I just told myself before I went on the trip that I wasn't going to restrict and that I wasn't going to worry about it and that my body would be able to recover no matter what happened in that week. And I really just enjoyed myself. I sat at cafes and I ate baguettes. She had gluten, which she hadn't touched. She had all the things. She's like, I had 0 symptoms, absolutely 0 symptoms. And I was like, well, isn't that interesting? Wow, what can we learn from that experience? Do you think maybe it had to do with how you were feeling? Like, were you enjoying yourself there? Yes, it was like I was just at peace. I felt so amazing. I wasn't stressed about work. I wasn't stressed about family. I wasn't stressed about finance. I said, well, do you think maybe that's a really big contributing factor to your GI symptoms? And so there are moments sometimes that we can just connect the dots. Like, that was a really specific and great aha. And it took a long time to get there because this wasn't information that she shared for a long time, right? But we got to the point that there was about a 70% reduction in symptoms. And over the 6 months, she really increased food tolerance pretty dramatically and was able to increase food variety. But this is somebody that I had to go so incredibly slow with, and overall developed an ability to relate to her symptoms with greater ease. And I think that was the biggest transformation, right? That was the biggest transformative piece. It wasn't that she was able to finally eat 2 carrots instead of 1. It's that she was able to relate to those symptoms. So, okay, curious compassion. I'm a little bit bloated today. I've also had a really stressful day at work. What are some of my other tools that I can go to feel a little better? What if I meditate for 20 minutes right now instead of making dinner? What if I lay down with, a warm cup of tea, or sit with a warm cup of tea and really just sort of settle my nervous system? That was a really huge moment and shift for this individual. So that blame spiral that I talked about, you're going to see this in practice. I'm sorry to say, but I do promise. You'll hear things like, what did I do wrong? What food did I eat that caused this? This like, oh, I shouldn't have had that food. I shouldn't have done this. I'm bloated again. Why am I bloated again? I can't eat anything without a reaction. I don't trust my body. I don't like this body that I live in. I don't like these symptoms. It's really challenging. It's very challenging. And there's a very deep empathetic part of me, right? And I think that's why I work well in this population, because I can hear those things and hold space for it and offer not solutions, but just a different way to relate to what's happening. So talking a little bit about on what's happening on the other side of this blame spiral, grief. Maybe is there some grief that you're not in total control over your body, right? That idea that you want to know exactly if you eat this, that you will have that symptom, but when that doesn't happen, it sends you on a tailspin, right? It is a grieving process to understand that we aren't in total control of our bodies. That's truth. That's the truth. Grief, that it's hard to be in a body that causes pain and discomfort. It is hard. That is true and accurate. But in individuals, especially, because what we're seeing in research is that individuals can go through the recovery process, refeed, be eating a normal caloric load, work tons on body image, in so many ways, be in such a different place and still have GI symptoms, still have it. So there's a lot of grief there to live in a body that causes pain and discomfort sometimes. A lot of people might have symptoms not because they're doing something wrong, but maybe because they have a medical condition or on a healing journey. So I'll offer that to individuals. Listen, this is not because you're doing something wrong. You're on a healing journey that's very unique to you. And so we have to be compassionate about that. And yes, it's okay to feel upset. It's okay to feel upset that you're in pain right now. That stinks. That sucks, right? Just being really, really clear. I hope that's helpful. Okay, next question. There are a lot of dietary interventions that can be very healing. I agree in cases such as SIBO, IBS, Crohn's, UC, etc. How are you approaching these topics to support clients without being triggered? I'm going to sound like a broken record here, but again, I'm going to go towards these non-food interventions probably first, right? So in an individual that comes to me, I'm going to want to make sure that we have some other sort of tenets in place. We've laid a really solid foundation of non-food interventions before we go into any sort of dietary shifts. The CNS toolkit is robust for digestive disorders. We have such incredible training around gut health, around understanding how to alter the gut microbiome and support intestinal permeability or the intestinal lining. There's so much that we can do to support GERD, support reflux, to support constipation, so much that we can do. So dig into that toolkit. And then when we're thinking about these dietary interventions, you're absolutely right. There's a ton that can be incredibly healing. We just have to be gentle about them. We have to be really gentle about them. So, I have an individual that I worked with, and I can't remember if I have a case here. I do. We'll talk about that one, but I'm going to mention this next piece, who had Crohn's and also a pattern of disordered eating, not necessarily recovering from an eating disorder, but I would recommend dietary interventions to help her build a toolkit to recognize when she was starting to potentially going to have a flare up, and feel really confident that she was able to reach into her toolkit when the flare up would happen to sort of calm down that symptom picture. And sometimes that was things like pretty simple things like, hey, listen, when flare ups are happening, we're going to change the texture of food, right? You're going to do more cooked food, more soups and stews. You could do things like green juices to get in some good nutrients, but your body's not going to be challenged by the fiber. So there are things that we can do in this dietary intervention space that isn't so punitive, eliminate all the things. You can't ever touch gluten and dairy again. That's not going to happen in an individual that has an eating disorder. I mean, it would happen, but it will trigger behaviors. I hope that's helpful. So in this case specifically, Carrie, 29-year-old therapist, 2 years out of recovery, anorexia, very straightforward, very clear that recovery was fundamental for her, but she had a lot of GI symptoms. So IBS, SIBO, breath test confirmed, severe constipation, and severe, very painful bloating. So would say, sometimes I wake up in the morning in just agony and have this big, huge dent in my stomach that wasn't there the night before from the elastic of my pajama pants because overnight I'm bloating so severely. She did not want to touch her diet at all and was really I'm proud that she was so clear, but she was also, a therapist. So she was newly a therapist, and she was very aware of things that would potentially trigger those behaviors and was so committed to recovery, really happy with her relationship with food. So here's sort of where we went. So because we had a SIBO breath test confirmed, we did do an antimicrobial SIBO protocol. It recommended things like Espularti, Modal Pro. We did not touch her food. I mean, didn't touch it. Not at all. So recommended some supplementation. After 6 weeks of this protocol, she had a 50% resolution of symptoms, regular daily bowel movements, the bloating reduced to tolerable on most days. I was successful. It's fantastic. But she still wanted to work on some of the bloating because 50% was not enough. We wanted to get a little bit further. So step 2, we added in some additional gut healing. We did things like GI Revive, some DGL. We changed her probiotic. Didn't touch food. Not touching it, not one bit. After 4 weeks, we had an additional 20% resolution of symptoms, but she still had really bad bloat after breakfast, and that would set her up to not feel good through the day. So we had a very gentle discussion around her breakfast, which was cereal and milk every morning, and she loved it, and she didn't want to touch it, and she didn't want to talk about it for 10 weeks, right? I don't want to touch it. I don't want to touch it. I'm really happy with it. I'm really happy with it, but I'm feeling sick, So this is, there are a lot of challenging navigation skills here, right? So we had a really just gentle discussion. Hey, are you open to maybe just trialing a different breakfast just to see what happens? And we also suspected that onions were a trigger because she was noticing that, especially when she was going out to eat and would have onion heavy foods, that she would just have this very, very uncomfortable bloat. So she was open to a dairy elimination trial. So we did a 2-week trial because I set timelines. Whenever we're bringing in any type of dietary elimination. And after 1 week, she was like, you know what? I can't deny this. I feel much, much better. So that was great information, right? It was great information that was supportive, and it wasn't placing blame, but it was saying, well, this might be a food that maybe at this stage of your healing journey is not fantastic. And I do that a lot too, where I'll say, hey, listen, this doesn't mean that you don't have dairy for the rest of your life. It just means that right now, as you're on this healing journey, we're giving your body a little bit of a break from it, but we're going to bring it back in. 2 months later, her bloating episodes were reduced to less than 1 time weekly. She typically still have some GI symptoms. Mostly her constipation was resolved. Having daily bowel movements, not every day felt as complete as she would like it to be. But this was a successful case that took time. It took time. And so when we say, there are really successful dietary interventions, they just might not be appropriate for the individual sitting in front of you, and we might need to dig deep into that toolkit. Okay, this next question, I think this is going to wrap us up here. Those with symptoms of orthorexia, they're obsessed with their health and obsessed with only eating the healthiest foods. Oh man, so much work to do here, and this is a huge, huge population. Language prompts and tools, address food fears, exercise flexibility around food. I'll question things. Hey, what do you think will happen if you eat a cookie? Normalize flexible eating, model flexible eating. That is something that I do all the time, and I pride myself on. I am never just showing that I'm eating kale, in the most perfect scenario. I'm eating burgers. When I'm traveling, I use that as an example all the time. Hey, listen, food flexibility, it's a beautiful thing. It's a beautiful, beautiful thing. So there's a lot of work to do here, but as a practitioner, if you can normalize that sort of flexible eating and model flexible eating, it can go very far. I recommend that they detox their social media. I sit down with clients and do it all the time. I'll say, you know what? I think we're at that point that we want to look at your Instagram. So let's scroll together. Let's scroll together and see if there are supportive accounts for you to follow and unsupportive accounts for you to follow. And sometimes we will do a massive unfollow, like a massive detox unfollow, because that messaging, that constant messaging is really not supportive for an individual like that, like this. And we'll do gentle challenges. We'll gently add in sugar. We'll gently add in carbohydrates, the things that they're most afraid of. In this population, we oftentimes have to do a ton of self-image work, right? So is this orthorexia an obsession too with the size of their body? Again, normalize that dietary flexibility. This is a caution. Food is medicine style education in these individuals is fuel on the fire. So an individual that is displaying these orthorexic behaviors, this obsession with health, obsession with only the healthiest foods, they are not going to respond well to let's talk about food as medicine. It's just not the right message. So if you're a practitioner that is your jam, and fantastic, I am right there with you, but I'm never having that conversation with an individual like this. Here's an example. Joy, this reminded me of a client of mine. She's a 30-year-old professional. Exactly that profile. So orthorexic, extremely restrictive behavior, so many rules, like really rigid rules around food, rigid rules around movement, an absolute perfectionist. She had recently started binging, and that's why she came to me. She didn't like the binging behavior that was happening. She was okay staying in her restrictive zone, but once it came into binging, it was terrifying. A lot of GI complaints. So bloating, discomfort, constipation. So what did we work on together? We worked on regular eating. That was the first thing we did. This is an individual that was like, I will only have, one, gosh, I'm trying to think of exactly what it was that she ate, because I think sometimes it's helpful to hear that. There was never breakfast. Breakfast didn't happen because she was intermittent fasting. So there was never breakfast. And then lunch was usually something very, very small. So it would sometimes be, maybe it would be a smoothie, or it would be a bar, or it would be a yogurt, but it was like the best of the best of the best of the best yogurts, right? Only plain, of course, a homemade granola, berries, and the chia seed and the flax seed. And she did all of those things, and that would be lunch. And then she would have a very sensible dinner, right? Just vegetables, sensible to, that's not those aren't my words, just vegetables. And then sometimes that binging would happen. So we really worked on this regular eating. I said, intermittent fasting is not an appropriate tool for you. We have to take that off the table. Can we bring in some breakfast? I really wanted to get her to see what it felt like to have more regular food, so there wasn't this urge that was happening at night. We really worked on decreasing these eating disorder behaviors. So it was a decrease, right? Worked on the restrict binge cycle. We talked a lot about over exercising. It took weeks and weeks and weeks for her to agree to eat both breakfast and lunch. She would, like I said, only eat a bar sometimes for lunch. We really worked on her exercise routine, because she would do sometimes 6-7 classes on the weekend, did a ton of self-image work. 3 years later, she's in, now this, I mentioned the timeline because this is a long time. She's in a really wonderful relationship, balanced with food and exercise, consuming a very normal caloric load. Her GI symptoms have fully resolved, but it took a very long time to do this work. And we had to be really clear about not using that sort of punitive language around food. So as our final reminder here, our supportive toolbox is full. It is full, and we just want to keep filling it up with compassion. We can use testing. You can be supportive in these individuals. We can use supplementation. We can lean on pelvic floor therapy, hypnosis, meditation, breath work, some vagal stimulation, squatty potty, supportive foods, adding in, setting realistic timelines and expectations. So thank you so much for joining me today for this session. If you have any other questions or concerns, please feel free to reach out to me directly, Abra at Abra Pappa. You can find me on Instagram at Abra Pappa. And here's my big old list of references. Big old list, but like I said, research is pretty small in this area. Okay, I hope you have a beautiful, wonderful day.